Good evening and welcome. Welcome to tonight's Thrombosis Canada webinar entitled Atrial Fibrillation and Venous Thromboembolism in the Emergency Department. My name is Eddy Lang. I'm on the board of Thrombosis Canada and I'm an emergency physician in Calgary, and I have the distinct pleasure of being your moderator this evening for what will certainly be a terrific presentation. Holly, could we bring up the next slide? I just want to remind you that we're opening the chat function throughout the whole webinar. Feel free to pop in your questions and your comments. Also, you will be seeing some polling, so be on the lookout for that. It'll help us really get a feeling for the group's practice pattern and where things are at in your neck of the woods. I'd like to tell you a little bit more about this program. This is the second webinar of two that's being presented. You see the Scientific Planning Committee, and of course, Dr. Andrade and Dr. Shivakumar are both presenting tonight, but we have representation from critical care, neurology, and two emergency physicians as well, including myself. Next slide. I'll tell you about my disclosures. I do receive, I have received honoraria from as listed and as listed there, but we just want to highlight that anything that I am involved with where on consulting fees or educational support comes in from an industry-related project, I will redirect that to the Calgary Health Trust to support emergency medicine training for research trainees. Next slide. This program was supported by Servier and has not received any in-kind support. Both Dr. Andrade, Shivakumar, and myself are eligible for honorarium from Thrombosis Canada, and for full transparency, Servier may benefit from the sale of a product that may be discussed in this program. Next slide. But we do our best to mitigate this bias by having our program reviewed, peer-reviewed by Thrombosis Canada, and the recommendations are generally guideline-based, accepted by our profession, although you'll hear about a little bit of, maybe a little bit of a separation between Canadian emergency physician guidelines and Canadian Cardiovascular Society guidelines tonight. We try to do this to the best of our ability to justify accepted standards. Next slide. This is an accredited program, so if you've signed up, and especially if you're involved in the discussion, you can claim both Royal College and Canadian Family Physician College hours of group learning. Next slide. Broad strokes, what we're trying to accomplish through this program is really to talk about best practice models and look at some treatment recommendations based on the best available evidence and guidelines. Think about diagnostic criteria applied to patient interventions and management plans, and also think about special populations. It's not a one-size-fits-all type of approach in some of these conditions, and we're going to challenge you with some not uncommon, but some perhaps challenging scenarios. And we're not only going to talk about the benefit, but about the potential harms of medications and how to mitigate the risk of both establishing a disease and a related treatment. Next slide. So if you were with us last week, we had a great session. Ted Ween, who's a well-known stroke neurologist and member of the Canadian Stroke Best Practice, was with us and presented his take and the Canadian Stroke Best Practice group's take on cerebrovascular emergencies in the emergency department as they relate to investigation as well as anticoagulation. And you can definitely catch these on the Thrombosis Canada website. Next slide is to tell you about tonight's exciting cases. We've got Sudeep, who is going to be presenting on a young woman with a DVT, who's a hematologist at Dalhousie and has bravely endured the Hurricane Fiona ravages on Halifax to make it here tonight. And then coming to us from Vancouver will be Jason Andrade, who is presenting a case of AFib and a patient with chest discomfort. Next slide. I will now gladly turn things over to Dr. Shivakumar.
Well, thank you, Eddy. Thank you, Eddy, for the introduction, and thanks to Thrombosis Canada for inviting me to speak today. The case I'm going to be talking about is a case of venous thromboembolism, and specifically a deep vein thrombosis, or DVT, in a young woman. Next slide. These are my disclosures. I have research funding from CIHR, and I have received honoraria as listed below. So at the end of this case, our objectives are that participants will be able to evaluate a patient with symptoms of a new DVT or PE, and then determine the best initial and ongoing management of an acute VT, including the situation where somebody progresses on anticoagulation, and to talk about the advantages and disadvantages of various anticoagulation options. Next slide. So this is the case, Miss JL. She's a 36-year-old woman who presents with 2 days of left calf pain, which she describes as a crampy calf pain that really is kind of like a Charlie horse that doesn't go away. She also notes that it's accompanied by swelling of the left leg only, which really raises everybody's suspicion for a diagnosis of DVT. On history, she actually did start a new oral contraceptive about a month ago. It was an estrogen-containing oral contraceptive, but no other provoking factors, and specifically no recent surgery, trauma, or immobility. She works as an online yoga and Pilates instructor and is quite active. She's previously quite well. She does have a history of asthma and uses a salbutamol puffer before physical activity only, but really does not have any significant limitations to her exercise tolerance. And her only medications are the salbutamol puffer as needed and the oral contraceptive pill. On triage, she gets labs done, and her D-dimer is elevated at 990. It is a positive D-dimer in case you use have a center that uses a binary D-dimer. Her CBC is normal, and it's always important to ensure that in a suspected VTE to get a baseline for the hemoglobin and platelets, as you are potentially going to be starting an anticoagulant. Normal electrolytes, and her kidney function is good, which is also important because that may alter your choice of anticoagulant. When the emergency physician assesses her in the emergency department, she finds that the patient has a heart rate of 68 and a blood pressure of 110/80, which is consistent with her previous blood pressure, which is very reassuring. Her oxygen saturation is 97% on room air. General exam, chest, heart sounds, abdomen is unremarkable and normal. But when you get down to her legs, her left leg is slightly tender to palpation over the course of the deep veins in the back of the calf. And there is some mild swelling, nothing dramatic. There's no pitting edema. There's no varicosities. Because of this presentation, and she goes on to receive compression ultrasound. And ultrasound confirms the presence of a left leg deep vein thrombosis in the proximal femoral vein, so a true DVT. Next slide. So the first question, and this will be a poll, is how would you treat this patient? The first option is low molecular heparin alone, so just low molecular heparin injections and sticking with that. The second option is low molecular heparin bridging to warfarin, so 5 to 7 days of low molecular heparin and starting warfarin as well, and discontinuing the low molecular heparin when the INR is therapeutic and they've had at least 5 days of anticoagulation. And the third option is a direct oral anticoagulant. And the options now include apixaban, dabigatran, edoxaban, and rivaroxaban. So I'll let you vote there. And I think we can see the results. That's great. And 97%, overwhelming majority chose the DOAC. So we'll talk a bit about that. Next slide. And next slide again. Great. So this would be consistent with recommendations from various guideline groups, including the CHEST guidelines, which really are go-to for thrombosis guidelines. Thrombosis Canada as well would have the same recommendation in their clinical guides. The recommendation in the CHEST guidelines reads that in patients with a venous thromboembolic event, they recommend a DOAC, apixaban, dabigatran, edoxaban, or rivaroxaban over a vitamin K antagonist such as warfarin as the initial treatment in the first 3 months. And this is a strong recommendation with moderate certainty evidence, as there are multiple large randomized trials comparing each of these agents to warfarin for the treatment of DVT and PE, with non-inferior, with all of them showing at least non-inferiority in terms of recurrent thrombosis, which is the efficacy outcome, and bleeding complications, which is the safety outcome. Next slide. So in this woman, you know that she has a DVT, and you're going to start her on anticoagulation. She started the oral contraceptive, an estrogen-containing oral contraceptive pill, a month ago. So the question I pose is, would you stop the oral contraceptive pill at this point? Yes or no? Yeah, so this is great because we have more of a split here, with 70% of participants saying that they would stop the oral contraceptive pill and 30% saying they wouldn't. And I love this question because I think, you know, there's different ways of looking at it. And every time I ask it, I always get a wide variety of answers. You know, there's a split between people who would stop it right away and not stop it, and those who would continue it. And I'll just take a second to try and explain my rationale for why I would not stop the oral contraceptive pill at this point in this patient. Of course, the reason to stop the oral contraceptive pill is that we know that estrogen-containing oral contraceptive pills increase the risk of a DVT or PE. They increase the risk about 5-fold. So it is a semi-provoking factor. Not like surgery, trauma, or immobility, but definitely increases the risk compared to those who are not on the birth control pill. Knowing this, many would want to stop the birth control pill. It's a provoking factor. You know, the patient might want to come off it because they know that this may have played a role in them developing a DVT or PE, so why continue on it? The reasons not to stop the oral contraceptive pill are a bit less intuitive, but I'll go through them. The first major reason is that the oral contraceptive pill is being taken for a reason. And two of the biggest reasons to take the oral contraceptive pill are to provide contraception and to potentially control periods or heavy menstrual bleeding. And that may even just be a secondary byproduct of being on the pill. Now, in this patient who has a new DVT or PE, you're starting them on a blood thinner. And the first thing is the oral anticoagulants that we use, warfarin and the DOACs, are not to be used in pregnancy. Warfarin is teratogenic between 6 and 12 weeks gestational age. The DOACs, we don't have clear data, but we would avoid them in pregnancy because of the risk of teratogenicity. So if the patient is not made aware of this or is not using a second contraceptive method, the risk of pregnancy is there. The second issue is that if the woman does have heavy menstrual bleeding, well, the oral contraceptive pill may be alleviating that to some degree. At this point, if we are introducing an anticoagulant, a blood thinner, that may increase the incidence of heavy menstrual bleeding. As well, if we're withdrawing the oral contraceptive pill, that may just lead to horrendous periods. And we have seen many women who have just terrible periods, which are, unmasked by starting a blood thinner and stopping the birth control pill, to the point where women are changing their pads or tampons every hour, not able to leave the house, not able to go to school, etc. All of this doesn't, it matters, but the reason they're on the blood thinner is because of the blood clots. So if, it's not a safe thing to do to continue the birth control pill, that would be something that would be very important. However, we do have a lot of emerging evidence and a lot of, good quality evidence that has shown that patients who are on a blood thinner and the oral contraceptive pill are at low risk for another clot. They are not, being on the combination is not associated with an increased risk of another clot. So we do feel that the woman is adequately protected against further or recurrent venous thromboembolic events while she is on anticoagulant therapy, and thus it is safe and reasonable to continue the anticoagulant. Again, at this time, it is a discussion between the provider and the patient, as the patient may have, a strong feeling either way. However, my recommendation would be to continue the oral contraceptive pill at this point, and then to look at that at a later date, especially if the patient is going to come off anticoagulation in the future. At that point, I would recommend that estrogen-containing birth control pills be stopped or considered to be stopped, and looking at other options, including progesterone-only pills, which have their benefits and disadvantages. Of course, if you miss a dose, you lose your protection. They have other side effects. They have to be taken at the same time every day. There's also patches and the IUDs, which also have other side effects. The Mirena IUD specifically, the progesterone secreting IUDs, do not increase the risk of DVT and PE, and we actually have some evidence to support that. Whereas all the other contraceptive options do have murky evidence with some trends towards a slight increased risk of venous thromboembolic disease when off anticoagulation. So I do feel that heavy menstrual bleeding may be further aggravated if the oral contraceptive pill is stopped. So it is reasonable to continue in the acute phase. I do see that at the bottom it does say that DOAC can also help with heavy menstrual bleeding, and I'm not sure I've forgotten where that line came from, but I probably wouldn't say that. I would say that DOACs do, increase the risk of heavy menstrual bleeding, and just like warfarin or any blood thinner can. So it is something that I find is, patient dependent, and some drugs work better than others for some people. But the point stands that it is reasonable to continue the birth control pill in combination with anticoagulation when somebody is diagnosed with a DVT or PE. I'm not sure if I convinced you, but hopefully I've made a bit of a case. So Miss JL, 1 month, she started on rivaroxaban 15 milligrams BID for 3 weeks with food, and then transitioned to the standard dose of 20 milligrams once daily thereafter. Within 1 week of starting anticoagulation, her leg swelling improves and she has a great response as her legs are back to normal. But 1 month later, after the initial improvement, she develops shortness of breath on exertion. She presents again to the emergency department and undergoes a CT scan with PE protocol, and this confirms a right lower lobe pulmonary emboli. She's hemodynamically stable at this time. Next slide. So this is a case of somebody who appears to have had a recurrent thrombotic event while on anticoagulation. And whenever we encounter this, there are some considerations that can help lead to why this happened, if there's an underlying diagnosis, and what would be the best treatment going forward. The first is compliance. Has the patient been taking their anticoagulant? If there are missed doses, that may explain it, especially in the first month of therapy. Any drug-to-drug interactions, and warfarin is classic for this, as there are numerous drugs that can increase or decrease your INR. But the DOACs also do have drug-to-drug interactions, and it's worth checking into this. Some of the drugs interfere with the CYP3A4 pathway, so antifungals, antiepileptics, some antibiotics can alter the drug therapeutic level. If the patient was on warfarin, it is important to check the INR. Was it therapeutic? And not just at the time of presentation to the emergency department, but really over the last few weeks. Has it been subtherapeutic leading up to this, leading to suboptimal anticoagulation? If they were on a direct oral anticoagulant, was the dose appropriate? And because DOACs are used for atrial fibrillation as well as venous thromboembolic disease, and because there is a run-in phase for rivaroxaban and apixaban, where there's a higher dose for the first week to 3 weeks, It's important to note if they did get the appropriate dosing. If they're on any form of heparin, including low molecular heparin, it's important to check the platelet count. With low molecular heparin, HIT is unlikely, but still possible. So a drop in platelets would be a red flag there. And then some other things to consider. Are there any other symptoms that have come up, any constitutional or focal symptoms that might lead you to another diagnosis in this patient? We'll talk about cancer just in a second. Was the shortness of breath there initially? And sometimes we do see this where somebody presents with a DVT, maybe some shortness of breath, but they get the ultrasound, diagnosed with a DVT, and then a few days later, they have a bit of a flare-up of their shortness of breath and are diagnosed with a PE. Is this a true failure of anticoagulation or a true recurrent event, or was the PE just there all along? And really, in these cases, it's very difficult to know because you really have nothing objective to stand on to look at, and it really is just more a bit of detective work with the history and trying to sort that out. A lot of patients, 80% of patients are 80% better at 1 week, but there's about 20% of patients who do seem to get a bit worse in the first week and then get better. So is it possible that they just are starting to recover and this is a PE that was there at the beginning? And then in terms of other causes, are there other diagnoses or other circumstances that would have put the person at an increased risk of thrombosis that might have caused them to break through their anticoagulation? Is pregnancy possible? Pregnancy is a thrombophilic state. Is there an underlying thrombophilia? Do they have a significant family history of thrombophilias or signs of antiphospholipid antibody syndrome where they might have recurrent miscarriages, for example? And finally, going back to the constitutional symptoms, is there an underlying cancer? Cancer is a very thrombogenic state. Cancer makes the blood sticky. And a person with cancer has a 5-fold increased risk throughout their cancer journey of a recurrent thrombotic event. And we do know that patients with cancer and a thrombosis do worse than patients with cancer alone, and the thrombosis is harder to treat. They have more breakthrough thromboses. Next slide. So in this patient, she is diagnosed with a new PE with new symptoms 1 month later. So it is reasonable in my mind to think of this as a progressive or recurrent thrombosis or a breakthrough thrombosis. So how would you treat this patient at this point? They've been on the DOAC. They have been compliant. There's no signs of those other things that we had talked about, like pregnancy or obvious cancer or anything else. Would you switch to low molecular heparin? Would you switch to a different direct oral anticoagulant? If they were on rivaroxaban, would you switch to apixaban or dabigatran or edoxaban? Would you increase the dose of rivaroxaban back up to the initial 3-week dose of 15 milligrams BID because they have just gone down to the 20 milligram dose? Or would you place an Ivc filter? So the majority, 2/3, would switch to low molecular heparin, and the rest of the participants suggested switching to an alternate DOAC or increasing the dose of rivaroxaban back up to 15 milligrams BID. And I would switch to low molecular heparin, but I will admit that the data is sparse in this area. Next slide. So the majority of information or data that we have on patients with recurrent VTEs while on anticoagulation really comes from the cancer literature. And that's because cancer patients do break through more often. This graph is from our international registry for patients with cancer and a blood clot that occurred while they were on anticoagulant therapy, so a breakthrough clot. And you can see that the survival is on the y-axis. The patients who were on low molecular heparin after a recurrent VTE had a lower risk of another recurrence than those who were on warfarin. Next slide. The CLOT trial was the pivotal trial about 20 years ago now that looked at cancer patients with a new DVT or PE and randomized them to lomecriheparin or warfarin. And I just point out a couple of things about this graph. It's the probability of a recurrent clot. And the dotted line is the warfarin line, and the solid line is the lomecriheparin line. The first thing to note is that there is a clear separation of the curves, and dalteparin did decrease the risk of a recurrent clot. Now, the oral anticoagulant group had a risk of 17% having a recurrent clot, so quite high. In the lomecriheparin group, though, 9% still had, and that was the best therapy at the time, had another clot. So it happens quite a bit. Next slide. In terms of IVC filters, it is confusing because previous guidelines had actually recommended IVC filters in patients who had recurrent VTE while on anticoagulants. However, filters have become very controversial. We know that filters sit in the vena cava and prevent clots from coming up to the lungs from the legs, but let blood pass through. So it makes sense in somebody who's had a recurrent clot. But randomized trials have shown that IVC filters do decrease PE, but at a cost of increased DVT. And over the last several years, we've had more and more studies that show that the risk of recurrent DVTs once an IVC filter is placed is as high as 32%. It's prohibitively high, especially in patients with cancer. So it may cause more harm than good, and it's not recommended in more recent guidelines. And as such, I would only use an IVC filter in the specific case of somebody with a new blood clot where you cannot anticoagulate them for whatever reason. They have a surgery tomorrow or they're bleeding, because in any other situation, you're increasing the risk of a DVT. Next slide. So how about increasing the dose of lomecriheparin? Again, we don't have a ton of data, but this is a retrospective cohort study by Mark Carrier looking at 70 outpatients with cancer. And patients who were on warfarin with a recurrent clot were switched to lomecriheparin. Patients on lomecriheparin already had their dose escalated. So if you were on a low dose, you put up to 100%. If you're on 100%, you're put up to a higher dose. And the results were that there were a few patients, there were 6 patients, that had a second recurrent clot during follow-up. They increased the dose even further, and there were no further events at that time. In terms of bleeding complications, 4% of patients had bleeding complications, but majority were minor. There was 1 intracranial bleed associated with a brain tumor. All of this suggests that increasing lomecriheparin the dose is a reasonable option with an acceptable rate of bleeding. And again, this is a cancer patient population, but we extrapolate it outside that population because we don't have data, good data otherwise. Next slide. So it is important to note that with that those slides I just showed you, DOACs have not been, switching from a DOAC to lomecriheparin has not been studied extensively, so we don't know if it would still apply. However, in a breakthrough on a DOAC, based on the warfarin data, I think it's a reasonable thing to consider lomecriheparin. So the key learning points I hope to convey are that people with a DVT or a PE can have recurrent events. If they have a recurrent event on anticoagulation, think about compliance, think about HIT, if they're on heparin, cancer, pregnancy, drug interactions. It is uncommon to have a recurrent VTE, but it does happen. And there is some evidence for switching to lomecriheparin if on warfarin, especially in the cancer population. There's no clear evidence on what to do with the DOAC breakthrough. But again, as I mentioned, you can consider lomecriheparin based on the warfarin data. Next slide. And I think that's it. So thank you.
Thanks so much, Sudeep. That was great. Really important things for us to keep in mind. Thankfully, a lot of us do have benign hematology backup to help us with some of these decisions, but this was a great overview. I'm going to pass the baton over to Dr. Andrade. There are some questions in the chat. There is one question in the chat. I don't know if you want to weigh in on that, maybe through the chat, but let me pass things over to Jason for the next case.
Thank you so much. So it's my pleasure to join you all from the cardiology perspective to discuss a man with palpitations and chest discomfort. If we go to the next slide. Here are my disclosures. Next slide. So learning objectives for our case is basically to address the initial evaluation of a patient with new onset atrial fibrillation, particularly in an acute care environment. We're going to work through some scenarios to determine the best initial management for new onset atrial fibrillation and speak a little bit about the advantages and disadvantages of various anticoagulation options. Next slide. So our case today is Mr. LP. He's a 60-year-old gentleman who presents with a 10-hour history of palpitations, chest discomfort, and effort intolerance. It started the night prior after a dinner party. He tried to sleep it off, having gone to bed, but it did not resolve. So he came into the emergency department first thing in the morning. His past medical history is significant for diabetes, which has been known for 5 years. He has obstructive sleep apnea, but is non-adherent to his CPAP, and he has a background history of hypertension. His medications at home include ramipril 5 milligrams daily, metformin 1 gram twice daily, and he takes aspirin for primary prevention. Next slide. So in the emergency department, his examination shows he's hemodynamically stable with a blood pressure of 115/75. His heart rate is 125. His pulse is irregularly irregular. His heart sounds are variable. He did not appreciate any added sounds or murmurs. He appears uncomfortable and short of breath. However, his oxygen saturation is reasonable at 97% on room air. His chest is clear to auscultation. His abdomen is protuberant but soft, and he has no signs of volume overload or decompensation. The ECG, just go back, shows atrial fibrillation with rapid ventricular response. His GFR is normal, as is his electrolytes and CBC. Sorry, next slide. So this is how we structured the overall management of atrial fibrillation. So this is not necessarily specific to the atrial fibrillation within an acute care environment, but really focuses on the 4 areas where we want you from a Canadian Cardiovascular Society to sort of invest your efforts in order to improve the outcomes of our patients with atrial fibrillation. So from the point where AF is diagnosed, you want to think about reversible precipitants or triggers for the atrial fibrillation. Beyond that, we then get into sort of the 3 key management pillars. So stroke prevention and risk assessment, and we'll come back to that a little bit later. We have management of the arrhythmias. This is really the decision between rate control versus rhythm control. And then there's management of comorbid risk conditions or risk factors, and we'll go through that as well. The idea of breaking it into these different domains is really to highlight where the benefit comes from. So for patients who have atrial fibrillation, their mortality is reduced through stroke prevention therapies, as well as management of their comorbid risk conditions, whereas a focus on management of their arrhythmia and prevention of complications benefits them from a symptomatic standpoint, and with a secondary reduction in healthcare utilization. So we can go to the next slide. You can just go to the next one. So when we think about atrial fibrillation, especially in an acute care environment, it's important to think about whether this is primary atrial fibrillation or secondary atrial fibrillation. So what this is getting to is the idea that primary atrial fibrillation is, atrial fibrillation as a disease. It's a problem for that person, whereas secondary atrial fibrillation is kind of the atrial fibrillation is the red herring. It's there and it's a problem in sort of the acute situation, but it's not necessarily the issue at hand. And so secondary atrial fibrillation is atrial fibrillation which manifests itself in the context of some other issue. So if they present with pneumonia and that results in atrial fibrillation, or a pulmonary embolus, which then presents as atrial fibrillation. Now we can see it after any cardiac or non-cardiac surgery. We can see it actually with any acute infection and stressor. You can see it in thyrotoxicosis, or in the context of some medications such as ibrutinib. And so those things, the management would focus really on that primary problem. So you would treat them for their pneumonia and their acute medical illness, and the atrial fibrillation should settle down over time. Whereas if it's atrial fibrillation is the problem, and there's nothing else wrong with that person sort of acutely, and really the issue is the atrial fibrillation, then the focus of your acute management is going to be on managing that atrial fibrillation. Now, the key point here is that it's different than the triggers. So someone can have primary atrial fibrillation, or sort of a heart that wants to have atrial fibrillation, where it's triggered by alcohol or it's triggered by physical exertion. That's kind of the difference between the why is your primary or secondary, and the why now is the trigger. And so you typically want to address the triggers as well as the underlying arrhythmia in the long-term management of these patients. So you can go to the next slide. Click again. And so as you can see, we're not really going to get into the issues around risk factor management, largely because that's kind of outside the domain of acute atrial fibrillation management. So in the emergency department, you're typically not going to address weight loss and exercise prescriptions. But I don't want to negate the importance of that in the long-term management of atrial fibrillation. So within the CCS guidelines, there's a figure that outlines all of our lifestyle and comorbid risk condition targets. And so I ask you just to kind of focus on that later on when you're reviewing it on the whole. Now we'll kind of transition to the stroke prevention piece. And so you can click the next slide. And so within the structure of how we have the atrial fibrillation guidelines, essentially what we do is we dichotomize it into people you anticoagulate no matter what, and then people who don't have a specific reason for anticoagulation, but you apply a risk score. So the anticoagulation kind of no matter what is people who have atrial fibrillation in the context of valvular heart disease. So these are people with any mechanical heart valve in any position, or people who have moderate to severe mitral stenosis. And so last summer, or I guess last month, the Invictus trial was presented and demonstrated that NOACs aren't as good as warfarin for the management of stroke prevention for patients with valvular atrial fibrillation, in that case, rheumatic heart disease. And so in that group, we would give warfarin and not a NOAC. Same thing for mechanical valves. There was an older study done which demonstrated that NOACs were associated with higher rates of bleeding and thrombosis. And therefore, for patients with valvular AFib, we prefer warfarin. Other groups where we would anticoagulate irrespective of their risk score, so hypertrophic cardiomyopathy, amyloid cardiomyopathy, patients who have acute hyperthyroidism, all of those groups necessitate stroke prevention therapies. But in contrast to valvular atrial fibrillation, it's perfectly reasonable to use a NOAC in that group. If they have none of those things, then they find themselves within the category of what we call non-valvular atrial fibrillation. And that's where we use the algorithm that's on the right side of the slide. So the CCS algorithm is essentially a modification where we merge the CHAD score with the CHADS VAS score. We don't use female sex or vascular disease as indications for anticoagulation. Instead, what we've done is just taken the CHAD score and dropped the age. So age over 65, that group is an annual risk of stroke of about 2% per year. So then that group necessitates anticoagulation based on its absolute risk. If patients are younger than 65, then we look for a history of hypertension, heart failure, diabetes, or prior stroke or systemic embolism. If any of those are present, then again, we would use anticoagulation therapy. If none of those are present, then typically we would provide no antithrombotic therapy for the purposes of stroke prevention. Now, the one caveat there is if they have comorbid coronary disease or peripheral arterial disease, then we would recommend that they receive antiplatelet therapies as you would prescribe for those conditions. So that could be a single antiplatelet like aspirin or Plavix. It could be aspirin in combination with Plavix or aspirin with ticagrelor, or it could be the 2.5 BID dose of rivaroxaban in combination with aspirin. And the reason there is that the absolute risk of stroke, if you have atrial fibrillation and a history of coronary disease, isn't very high, in combination with the observation that those therapeutics, so the antiplatelet agents, will reduce the risk of stroke. Aspirin alone typically reduces the risk of stroke by about 20%, dual antiplatelets about 30%, rivaroxaban plus aspirin's about 40%. And so you do see some reduction. However, for patients who are at higher absolute risk of stroke, you really want to see the risk of stroke reduced with anticoagulation. Just go to the next slide. And so warfarin, we know, will reduce that risk by about 2/3. And so in patients who are at higher risk, we really want that additional reduction in the risk of stroke that comes with warfarin or oral anticoagulation therapy, recognizing that there is an increased risk of bleeding with those therapeutics. If you go to the next slide, click again. So within the Canadian guidelines, though, we prefer NOACs or DOACs in preference to warfarin because they have advantageous characteristics. So the first is that they're either as good or better than warfarin at reducing the risk of stroke. So you get about a 20% additional reduction above that 66% reduction you saw versus placebo, and it doesn't come with any increased risk of harm. So the risk of bleeding was not increased relative to warfarin therapy. And therefore, you now have an agent that gives you an efficacy advantage and a safety advantage. And if you look at the bottom of the slide, you can see that that fourth bullet or fourth line under efficacy is all-cause mortality. And so DOACs actually improve survival by about 10% over the improved survival that you saw with warfarin. So now you have a therapy that's actually preventing strokes, but making people live longer because of it. If you want to go to the next slide and click again. And so from a stroke prevention standpoint, I think it's pretty straightforward. Patients presenting with a first episode of atrial fibrillation absolutely need to be assessed in terms of their thromboembolic risk and absolutely need to have treatment provided when they're seen in the emergency department. The big question that is sort of the crux of the conversation today is this next bit, which will be the management of the arrhythmia. So just click and then come down. Click again, sorry. And so within the CCS AF guidelines, we tried to come up with sort of a simplified algorithm for the management of rate versus rhythm within the emergency department. And then there's a much larger algorithm that we use for sort of the chronic management. I click the first, or click, Holly. So the first thing that we consider really is just hemodynamic stability, right? So it kind of goes back to the ABCs. If someone presents to the emergency department, they're hemodynamically unstable with acute atrial fibrillation, which we define as hypotension, having an acute coronary syndrome or decompensated heart failure, then that person, you can go ahead and cardiovert. But the key point is that this should be a very rare event. There should be very few patients who are hemodynamically unstable because of their atrial fibrillation that requires you to cardiovert them. The vast majority either are going to be unstable because they have sepsis or some other condition that's leading to instability that's then driving the atrial fibrillation. So if their atrial fibrillation is the cause of this instability, then you kind of cardiovert them, get that under control, and then move on down the algorithm. Click, Holly. If they're stable, click again maybe. And then it comes down to the question about what are you going to do about their rhythm. So now you have time to make a decision, participate in shared decision-making with the patient in terms of what they would prefer. The options are acute rate control, so basically slowing them down to a heart rate under 100 beats per minute. The agent you use is typically dictated by their ejection fraction or whether or not they're sort of at risk or intolerance when you give them a calcium channel blocker. So preserved EF, beta blockers, or calcium channel blockers are reasonable. Reduced EF, then you're typically going to focus on beta blockers. If they don't have stability to tolerate the medication, so their blood pressure is a little bit soft, then you tend to use digoxin or amiodarone as a substitute. If you don't know their EF, then presume it's impaired and probably favor a beta blocker. The question about whether it needs to be IV or oral is discretionary, I think, left to the treating clinician. My personal feeling is that you don't need to rush to rate control most people, so oral formulations are reasonable because it also makes it easier to transition those people to those medications as they leave the emergency department in terms of their chronic management. In terms of acute rhythm control, there's some criteria that we use to favor rhythm control. So patients with new onset atrial fibrillation, typically we would not rate control them, we would acutely rhythm control them. There's evidence that emerged within the past year from the East AFNet study, which demonstrated that newly diagnosed patients with atrial fibrillation who received rhythm control had a subsequent reduction in stroke and mortality over the 5 years of follow-up. So really controlling the rhythm does have an advantage to patients in a randomized study. And so patients with new onset atrial fibrillation emergency department, typically we would favor acute rhythm control. And the question just comes down to whether or not you can cardiovert them then and there, or if you need to do something else. So either a TEE or provide them with a month of anticoagulation and bring them back for cardioversion. Do you want to click the next slide? So the way we have it within the guidelines is a consideration of two different things. So the one thing you're balancing is the risk inherent in the arrhythmia. And so this is how long have they been in atrial fibrillation? Have they been in atrial fibrillation for 12 hours or up to 2 days or longer than 2 days? And then the second piece is what is that patient's risk? So low-risk patients, you'll tolerate longer episodes of arrhythmia. High-risk patients, you'll tolerate shorter episodes of arrhythmia. And we'll show some data on this in the coming slides. So click. So the first question to the group is, if this was your patient, so a 60-year-old man with 10 hours of atrial fibrillation, he's diabetic and hypertensive, would you cardiovert him here and now, or would you delay the cardioversion 3 weeks of anticoagulation, or do a TEE? So I don't know if we have the results. There we go. Okay, interesting. So it's just over a 50-50 split. All right. So most people would not cardiovert. The answer I would provide is to say, yes, it's fine to go ahead and cardiovert him. So click to the next slide. So this is the important differences, let's say, between the CCS guidelines and the CAPE position statement. So the first point I want to make is both groups, both of these documents are incredibly well aligned. So they basically give you the same message in the vast majority of circumstances. There's only slight differences that are worth pointing out, and that's what's on this slide. So if we think about the pre-cardioversion risk assessment, this Canadian Cardiovascular Society uses the CHAD score, like the old CHAD score, whereas CAPE recommends the use of the CHAD 65 algorithm. From a CCS perspective, we had long conversations about this. The reason we're using the old CHAD score and not the CHAD 65, which is what we recommend for stroke prevention decision making, is that we have no data on the CHAD 65 in the acute environment. So the data we have regarding risk of stroke really comes off of CHAD score or a CHADS VAS score, but it does not come off of the CHAD 65. And so from an evidence standpoint, our strongest leg to stand on really is the use of the CHAD score, which is why it persists within this acute care sort of decision-making process, despite not showing up anywhere else in the guidelines. The other key difference is following cardioversion, the CCS recommends everyone be anticoagulated for 1 month full stop, whereas CAPE recommend that you consider that. You can get into the details a little bit more nuanced, and that's what's shown in the table. So if you're presenting with a sort of a short episode of atrial fibrillation, both CAPE and CCS say don't cardiovert those people if there's a history of stroke. The difference is CAPE says any history of stroke. So if the patient had a stroke at any point in the past, you would not cardiovert them even if they came in with 4 hours of atrial fibrillation. CCS says it has to be a recent stroke, so some event that potentially is new and cardioverting them might worsen. And the definition of recent is 6 months. For patients who are presenting later, so 12 to 48 hours, both say if they have 2 or more risk factors, don't do it. Again, the difference here is really whether it's CHADS or CHAD 65. Tangibly, that only makes a difference in that 65 to 75 year age group. The other 4 risk factors are the same between the 2 scores. Both agree for episodes over 48 hours, don't do it unless you have a TEE. We would not, for anticoagulation post-cardioversion, again, everyone should get it based on the CCS guidelines, whereas CAPE recommends individualizing that decision-making. DOAC is preferred for both. And then technically, if you get into the details, if you give them warfarin in the emergency department, we feel that they should be bridged with heparin until the warfarin is therapeutic, whereas CAPE does not say that. The reason that we believe that is important is because if you look at the time course for stroke after cardioversion, it's highest within 48 hours and then slowly decreases out to a week and then normalizes somewhere around 2 weeks. And so if you start someone on warfarin in the emergency department, you don't bridge them, you're basically leaving them unprotected in their highest risk period. So we thought that was important. Do you want to go to the next slide? Okay, so now here's the evidence that kind of informs that process within the CCS guidelines. So the first thing to recognize is that cardioversion is a high-risk period, irrespective of whether they're on anticoagulation or not. So if you look at patients who are just background atrial fibrillation, the monthly risk of stroke, if they're not receiving anticoagulation, on average is about 0.5%, so 6% per year. If they're receiving anticoagulation, that monthly risk is about 0.18%. So in that 30 days, just having atrial fibrillation on anticoagulation, your risk of having a stroke is, let's say, 0.2%. If you look at that same interval, but now it's around a cardioversion, if you're not on anticoagulation, your risk of stroke is 2% in that month. So that's the 24% risk of stroke annualized, but really that doesn't make sense. So really focus on the 30 days. That's a 400% increase over someone who's not cardioverted. So something about the event of cardioversion confers increased risk. An anticoagulated patient similarly has an increased risk, but it's only about a 200% increase. It's not a 400% increase compared to the non-anticoagulated person. Click to the next slide. If we look across multiple large-scale studies, so here you have up to 19,000 cardioversions within these series. If you cardiovert someone who has atrial fibrillation more than 48 hours, so that traditional bar of what we used to use, let's just put those studies together. It's roughly a 2% 30-day risk of stroke. So very similar to what I just said on the previous slide. If your AF is less than 48 hours, that monthly risk of stroke is now roughly 1%. So it's less than those over 48 hours, but it is not a low risk of stroke, right? So a 1% risk of stroke, I just told you on the previous slide that having atrial fibrillation in the background on off anticoagulation is about 0.5%. So it's about double, even with shorter episodes of atrial fibrillation. Just click the next slide. The important thing, though, is that anticoagulation across all of these instances, it reduces the risk of stroke significantly. So you're seeing, a 2/3 reduction or more, very consistent with the chronic AF management, but now focusing only on that 30 days around anticoagulation. And so for long episodes of atrial fibrillation, if you're anticoagulated, your risk of stroke is substantially decreased. For short episodes of atrial fibrillation, again, your risk of stroke is significantly decreased if you're on anticoagulation. It never quite gets back to that background rate of 0.2, but it's pretty close to it relative to what we see in someone who's not anticoagulated. Click the next slide. Okay, so now having heard that, you cardioverted the last gentleman. Will you give anticoagulation for the month after cardioversion or not? And the answers? Okay, good. I did my job. All right, so we can go to the next slide. Perfect. Okay, I guess I've answered this discussion question, which is the duration of treatment. So generally speaking, it will be a minimum of a month. And then what you would do is apply your CHAD65 algorithm after that to decide what the long-term management should be. So we go to the next slide. When you're thinking about this, so this is a new onset case. So in principle, this person coming to the emergency department has not had anticoagulation coming in. So now you're going to make a decision about what you're going to prescribe to them as they walk out the door. Strictly speaking, based on the labeling, edoxaban is the only one that has a label for initiation at the time of cardioversion. All of them have labeling around maintenance at the time of cardioversion. Whether you feel it's appropriate to initiate them on any anticoagulant is your personal choice, but just pointing out what the Health Canada labeling is. Go to the next slide. So, the question that always comes up is the data I've discussed to this point basically is saying you're not on an anticoagulant, you're on an anticoagulant. But the practical question that often comes out of the emergency department environment is, what if they've not been on an anticoagulant before? And so now I'm only starting it. And so this is where we can get into the Hanson study. And the Hanson study basically brings us that answer. So if you just click the next slide. And so what the Hanson did is it shows you results very similar to what we've been discussing. So no anticoagulation is at a higher risk of stroke relative to being on anticoagulation, and that risk is front-loaded. But if you look at the top right, you see it is forest plot. So the reference is the group that is on anticoagulation before and after cardioversion. The group who received no anticoagulation before or after is the middle dot, and that's about a 2.5 times increase. If you look at the top row, you have someone who's on no anticoagulation. However, they're prescribed anticoagulation at the time of cardioversion, and you see that their risk is very similar to what is seen with someone who was always on anticoagulation. So it highlights the fact that the clot develops at the time of the episode or following the episode. So you get atrial stunning, that becomes an issue, and that causes it to develop new clot following the cardioversion. So I'm going to click the next slide. I may move ahead a little bit here. So just 2 more points I want to make for this. Actually, yeah, these are these 2. So the first one is that historically, we've always used 48 hours as our cutoff point for defining whether it was safe to cardiovert. However, these 2 analyses really highlight that that risk period is not necessarily the lowest risk period. The lowest risk period is really within 12 hours. After 12 to 24 hours, the risk is increased. And that risk is also modulated by their CHAD score. So this is where the CCS gets their risk assessment, is based on this data. If your CHAD score is over 1 and you're presenting early, you're at high risk. Whereas if it's over 2 and you're presenting later, you're very high risk. So those pieces are what informed how we made that stratification around those 12 versus 48 hours, and how we integrated the CHAD score to define low risk in those categories. The last point I want to make before we wrap up the presentation is just on the next slide. And that's, what's the tangible risk of harm? So I'm recommending that we anticoagulate everyone for a month following cardioversion. And so there were a bunch of different studies done. There was the propensity matched Sudlander study, as well as randomized cardioversion studies. And what I want you to focus on is the graph on the right, which is the randomized cardioversion studies. And what they're showing in that highlighted box is essentially, if you prescribe someone an anticoagulant for a month in the emergency department at the time of cardioversion, their tangible risk of a major bleed is 0.5%. And if you look back at the Sudlander study, we actually contacted the authors and got some background information. They found that there was actually no difference in the rates of bleeding, whether they received anticoagulation or not. And so it did not seem to be a harmful piece if you prescribed anticoagulation to people after cardioversion. And from an absolute risk perspective, that risk of stroke is 0.5%. And so, or major bleeding, sorry. So your risk of major bleeding is almost half the risk of stroke if you don't anticoagulate them. So really, the harm that comes with the therapy is less than the benefit you're going to realize by providing it. I think we can probably wrap up the talk at that point, because I realize we're getting to the end of time.
Great. Well, thanks so much, Jason. Really appreciate this great overview and the unique insight you have. We are at the end of our time. We had maybe one quick question. Someone notes that if you have someone who is discovered to have valvular insufficiency, be it mitral or aortic, after they've been converted while they're being considered for conversion, and they have not had rheumatic heart disease, would you treat them as a valvular AF and avoid a DOAC? Is that clear enough?
Yeah, so I think what we tried to do in the guidelines in recent years was really refine what is the definition of valvular AF. So valvular AFib is a mechanical heart valve, not a repair, not a biological heart valve, right? It's really just a mechanical valve, and it's hemodynamically significant mitral stenosis. So we said moderate to severe mitral stenosis. If you have regurgitant valve disease, it does not count. If you have tricuspid valve disease, it does not count. If you have aortic valve disease, it does not count. Really, it is that mitral valve that causes stasis to develop within the body of the atrium that gives you a different mechanism of clot formation than just atrial fibrillation.
Awesome. Hey, thanks so much for that. And thanks to both of you for great presentations. Sudeep for answering a lot of the questions in the chat that came in. Two things, please fill out the feedback on the Survey Monkey that's in your chat window. And if you are interested in this kind of content, I would love to see you mid-October at the Western Harbour Castle in Toronto for what is now, I believe, probably the 10th annual Thrombosis Canada Conference, where you're going to hear lots more great talks from speakers across a range of disciplines and learn a lot more as it relates to bleeding and thrombosis risk. Thanks, everybody. Have a great night. Appreciate all your help.
Thank you.
And thanks, everybody, for coming.